okay, for potassium. Alright? Now identify the diffusion of potassium. Is it showing kind of a reabsorption or secretion? Reabsorption. Everybody agrees with that?
Yes.
And if you look at the sodium-potassium pump, what is it doing? Will it be facilitating secretion or inhibiting secretion? Facilitating, because it is bringing potassium inside the cell. It is increasing the amount of potassium inside the cell. If you have got more amount, then your secretion depends on that amount, isn't it? So this pump is the major pump which is bringing the potassium inside the cell. That is why, isn't it?
Yes.
So out of these mechanisms which are shown here, two mechanisms are showing you the reabsorption and one mechanism is indicating the secretion. Okay? Even though not directly, because direct secretion is not shown here. You cannot see, but indirectly this pump is a supporter of the secretion. Do you agree with that?
Yes.
Sodium potassium pump is the supporter of the potassium secretion from the cell. Because if this pump does not work, or if it becomes slow, what will happen to the potassium inside the cell? Reduce. So if potassium reduces in the cell, what will happen to its secretion outside? Because secretion means from high concentration to low concentration, sir. So it means this pump is very important. You got that?
Yes.
Factors on which potassium is based on or influenced by. Sodium intake, potassium intake, definitely. More potassium coming. You can excrete more potassium. It's easy. Aldosterone, you know the relationship between aldosterone and the potassium. I don't have to discuss again. It's done. Hydrogen ion, yes, we will talk about that. That is very interesting and that will go very long in your career years. You will be searching for the relationship between acid-base disturbances and the potassium homeostasis. That's a very challenging topic. Still we are working on this issue in our postgraduate studies and that's very fascinating. We'll come across so many new things. I'm not going to discuss all those things, new things with you here because it's beyond your scope at graduate level. But still, that is a recommendation for your higher studies. Whenever you go, even in medicine in 5th year and 6th year, you will find acidosis. Hyperkalemia or hypokalemia? Hypokalemia. Is it causing acidosis or alkalosis? So you have to see the relationships both ways actually. Who is affecting who and how is it happening? That is very interesting and you will inshallah come across. Diuretics, yes, that's a very, very important and discussable topic here and we'll talk about that. Okay? One by one, very quickly. Sodium is okay. If more sodium is filtered as a load and more sodium is passing in the tubules and more sodium is reaching your last parts of tubules, distal tubules and the collecting ducts, what will happen to the sodium hydrogen counter transport?
More secretion.
I'm talking first about sodium hydrogen counter transport, huh?
Yes.
Okay, which is modular in the tubule. So more sodium is reaching in the tubules. Now what will happen to this transport? Will it increase, decrease or same?
Increase.
Increase?
Yes.
Okay. If it increases, hydrogen will be secreted more?
Yes.
Okay. So what you are losing, hydrogen ions, you are losing more.
Yes.
Isn't it? So you may have a backlog or a background of slight acidosis or alkalosis. In alkalosis. Keep it in mind. This is one thing. Okay, keep it apart. We are not talking about that. Well, how will this affect the potassium now? Okay, you are talking about hydrogen and we say, no, we don't want to talk about hydrogen. We want to talk about potassium. So how will you relate this kathir amount of sodium coming into the tubules and how is it affecting your potassium secretion or reabsorption or whatever? What do you think?
It does increase the absorption of sodium, which leading to the secretion of potassium.
Acidosis will cause what?
Increase the reabsorption of sodium.
It will affect the potassium hydrogen pump or decrease its activity.
Potassium hydrogen pump?
Yeah, it will decrease.
Okay, this could be one. What would be the starting point, the major thing? Go for the major thing. Yes, these are all contributions which are you saying. Okay.
Sodium.
Yes, exactly. Sure. If sodium is coming in cathedral amount, so sodium is coming through the transporter and more amount of sodium will be reabsorbed. Sir? If more amount of sodium is modued in the cell intracellularly, now what will happen to your sodium potassium pump? Increase working. If your sodium potassium pump is working more very quickly, so what will happen to the potassium inside the cell? Increase. If the potassium is increased more, what will happen to the potassium secretion? So you have to make a chain starting your ibtidize from sodium in the tubules, and then you are working on the sodium hydrogen pump, and then you have more sodium inside, and then this sodium is stimulating the sodium potassium pump, and this pump is bringing more potassium inside, and this large pool of potassium is now available for secretion. That's it. You got that? Am I going fast?
Yes.
I'm repeating it. Okay. Yeah, sure. Okay, maybe. So, increased sodium is coming in the tubules. Large load of sodium is modular in the distal tubule or collector. Okay. Now that will stimulate the sodium hydrogen pump, because sodium hydrogen pump works with the help of the sodium which is modular outside. Okay. More sodium, yani more working of that pump. More working of that pump means sodium is coming in
Inside.
and hydrogen is going out. Plus, sodium is coming in. This is most important. If sodium is coming in, what is happening to the sodium concentration inside the cell? Increase. Alright. Now, this increased concentration is the major stimulus of the sodium potassium pump, because sodium potassium pump works on the basis of the how much sodium is modular inside the cell. If sodium is good, the pump is good. If sodium is less, the pump is less. So now if more sodium is modular in the cell, the sodium potassium pump will move very fast. If it is moving very fast, sodium is going out, khalas. But at the same time, potassium is coming into the cell. So now, as a result, potassium concentration will increase inside the cell. Shabab, you all know secretion depends upon the potassium concentration. Now, high potassium concentration means more secretion of potassium. Did you make the link between why sodium, high plasma sodium is causing secretion of the potassium ions? From starting point, you are bringing it to the cell. Okay? Everybody's clear about that? Great. Okay? This is what you have to make link, that how the mechanisms of working. Okay? Increased potassium itself will cause. Definitely. Okay? So you don't have to worry much about that. Okay. Aldosterone, you know the role of aldosterone. What is aldosterone doing? If aldosterone is increased in the body, what will happen to the potassium? If due to any reason aldosterone is secreted more, what will it do with the potassium? And if due to any reason aldosterone is inhibited, what will happen? So aldosterone can be the starting point. Yani, due to some reason aldosterone is increasing or decreasing for some reason, and now it will affect. And sometimes aldosterone is normal and there is something in the kidney going on, and potassium is maybe increased more in the plasma, or more potassium is reabsorbed. As a result, you have high potassium. Now this high potassium will affect the aldosterone. So you can think in both ways actually. If aldosterone is more, what will it do with the potassium? If potassium is more, what will it do with the aldosterone? Did you get that?
Yes.
That was a simple idea, but I'm not stopping here because one thing is left, and I want to discuss this thing with you, which is very, very important. And you just tell me about, you are using a patient of hypertension and anemia comes to you, and you are a doctor. You check his electrolytes level, and they are okay at the starting point. The blood pressure is high, he's having edema. And you're a doctor, you plan to give a diuretic, a good diuretic to start with, and you begin with a loop diuretic. Okay? Loop diuretic. You give. Okay? After some time, okay, you don't follow the patient, and the patient comes to you, maybe after 1 month or 2 months, you asked him to come and he did not show up. He said, why should I go to the consultant again and give Fulus to him again? He's calling me for the Fulus again and again, okay? So I'm not going to him, I'm having the drugs, I'll use them, okay? Without thinking that the follow-up is very important, because he's using some diuretics which are very strong and which are loop diuretics, causing loss of potassium or loss of some electrolytes. He doesn't know about that. The doctor knows that. Okay? That's why the doctor called him. He didn't show up. So then after a long time, he complains of weakness and lack of concentration and some changes in the body, and he was taken to the doctor again. And the doctor sees that, oh, he has to repeat the report of electrolytes and the acid-base balance. What kind of changes do you expect in the lab report of this patient who is taking without advice and continuous for 3 months? He was advised to take for 1 month, shahar only, and he was taking for Talata Shahur, and now he is coming to the doctor. So what do you think? Hypokalemia. Alright, in terms of potassium, most important thing, what else? Hyponatremia. He'll also lose sodium, no problem. Yes, definitely he will. And?
Doctor, can he have hypochloremia?
Hypochloremia. Alright, it's with sodium, chloride, they can go together. Yes? Yes. Hypochloremia also. What else? Alkalosis? Okay. How can you trace alkalosis? Good, go on. Try. Because I said electrolyte and acid-base balance both. I want the answer. You are talking in terms of electrolytes, you are losing takriban all electrolytes which are coming in the tubule.
Sodium will try.
Yeah.
Stimulate the hydrogen.
Very nice. The same thing which we talked about just, okay? Increased sodium. If the sodium, sure, what is the action of the loop diuretics? What are they doing? Blocking the khalas. So sodium is not reabsorbed from thick loop of Henle. Yani, what is happening? Large amount of sodium is going to the next station in the collecting ducts and the distal tubule. If kathir amount of sodium is going in unabsorbed form in the collecting ducts, what will happen to the sodium hydrogen exchange? Increase. What will happen to the hydrogen ion secretion? Increase. So what will happen in the body? Alkalosis. So what kind of alkalosis? Metabolic or? Okay. Hyperchloremic or hypochloremic? What do you say? It's hypochloremic metabolic alkalosis which is happening along with that. Did you get that? Drop down. Okay. The doctor says, oh, this patient doesn't understand me and he's a risky patient. So he will not again listen to me. He changed it and he gave the thiazide diuretics instead. Okay, to the same patient. Say, come on, I'm changing it, and now you take. And he starts taking thiazide diuretics. Okay. He was taking thiazide, and all right. The doctor again advised that you have to see me after 1 month. So he went again with the therapy. Okay. After 15 days, he forgot that he has to go again to the doctor, and he started taking the thiazide diuretics. But he felt that his edema is not decreasing as much as it was decreased with the loop diuretics, okay? Because now he can compare that the previous drug was better and this drug is not so good really, it is not relieving me from edema, okay? So what he does is that, say, I'll not go for and I'll not spend methane real again please, okay, for this consultant. What I will do is, I'll see one of my cousins or doctors who's a general practitioner and I'll ask him phone that I am taking this drug. So he asked by phone that I'm using this drug and I'm not getting relief from the edema. There was another drug. So the young doctor, okay, just graduated. Say thiazide diuretics, say khalas, because he was following some of the basic rules what he does in the clinics and all those things without having some experience of it. He said, this thiazide, oh khalas, no problem, it is a safe drug. You can double the dose, okay? You just take 2 tablets instead of 1, inshallah you will get relief of edema. He said, khalas, okay, no problem. Jazakallah khair. He said, that's it. So he starts taking 2 tablets, okay? Now, his edema was relieved, but he was taking it very religiously in a very committed way, every day 2 tablets, 2 tablets. After 2 weeks or 3 weeks of use, the edema was decreased, but then again he starts feeling some weaknesses in body, the muscles were not working, standing, sitting and pain and some like Russia also, and all these things are happening, okay? He again got confused that why is it happening to me again and again? He said, no, maybe I did a wrong thing. I wanted to save Fulus actually, but now I'm losing my health. I have to go back to this consultant again. So he went to the consultant again. The consultant did not say anything because he understood the psychology of the patient. But he repeated the electrolytes and the acid-base balance. What disturbance do you expect in him? Now, hypokalemia, still hypokalemia? Yeah, because now he has doubled the dose, so it is now giving very good diuresis, but at the expense of loss of potassium ions, isn't it?
Yes.
So he's losing potassium ions. Sodium also? Yes. Okay. For these major effects, I'm not saying other ions will also be disturbed, other effects will also be produced, but the major electrolytes, loss of sodium and potassium,
Yes.
loss of chloride also, I believe,
No,
Yes.
along with the sodium, if you say, isn't it? What else will happen regarding acid-base balance?
Hypocalcemia.
Hypocalcemia? Because you're talking about the thiazide action on calcium. What will happen? Alkalosis? Same or different? Same? So it will again cause metabolic alkalosis?
Yes.
You know, the same picture repeated actually, okay? It was because he did something wrong. Again, he did not follow. So it's not the matter of Falus only sometimes. It is the matter of why the doctor is giving advice. Doctor knows why is he calling the patient again. And the patient should commit and should stick to the follow-up visit, which is very, very important. Don't change the therapy by yourself or by any other's advice, okay? Another patient who wanted to receive treatment for edema and hypertension and other issues, and diuretics were indicated, but then his potassium level was found to be high, okay? And the doctor gave him a diuretic, and that diuretic was suitable for him. His potassium level was low actually, not high. At that time it was low, okay? For high you can choose the previous two, loop diuretic or some others also, which are potassium losing diuretics. Khalas, no problem. But his potassium level was a little close to 3.1 or 3. The doctor decided not to give furosemide, not to give any thiazide diuretic, but instead choose a potassium sparing diuretic. He chose one and he started giving. What diuretic had he chosen? For example, yeah, spironolactone or similar family drugs, okay? Something like that, okay? Alright. What would be the consequences of the patient was old, right? The patient was old with hypokalemia or borderline hypokalemia, and the patient was forgetful also, okay? These forgetful patients are very dangerous. Sometimes they take drug, sometimes they miss the drug, sometimes they forget that they had taken the drug, they take it again. They take 2 tablets or 3 tablets instead of 1. If you are on this side, you are a very dangerous patient because you are taking 2 times or 3 times the drug, which should be taken only once. Okay? So if this was the picture, what could happen to that patient after weeks and weeks of therapy?
Hyperkalemia.
Hyperkalemia. All right. So he will come up with maybe some of the symptoms of hyperkalemia. Okay? And all right, and that could add, one more thing could add there, and that would be acidosis. So it will be, yeah, hyperkalemic metabolic acidosis. This.
Why is this?
Yeah.
Sodium is going out.
All right. Can you explain why acidosis can happen? What was the reason? Why acidosis?
Because the potassium is reabsorbed, so there will be no counter transport between potassium and hydrogen. So the hydrogen will be retained in the body.
Sodium hydrogen counter transport. It's there. And the active transport, active pump, hydrogen pump in there.
Okay, what kind of drug did you choose? What was the drug that you chose? First of all, tell me.
potassium sparing.
Potassium sparing. Give an example.
Aspirin or
Spironolactone. What does it do?
I don't know.
Anyone can help that? What does spironolactone?
Antagonize aldosterone.
It antagonizes aldosterone. It is the competitive inhibitor of the aldosterone, and it blocks the action of the aldosterone. Now think that you are blocking the action of the aldosterone. All right. What are you doing?
Sodium not absorbed.
Okay. So diuresis.
Potassium not secreted.
Potassium not secreted. So what will happen to potassium?
Increase.
Okay. What else is not secreted?
Hydrogen.
Hydrogen is not secreted. So what will happen in the body?
Acidosis.
So acidosis and hyperkalemia, both are happening together. Okay, because you are working on the aldosterone. That was the reason. You block the aldosterone. Because of the aldosterone blockade, you will develop this kind of picture. Did you get that? Yeah. Everybody's clear about that? Okay, great. Very nice. Now, a person comes to you, he was a patient of some metabolic disorder, and when you see his electrolyte picture, he needs diuretics, and you are a doctor, and he needs his acid-base balance shows that the pH, the plasma pH, is about 7.2. Okay, it was 7.2. All right, he's okay so far. He's a little ill, but his pH is 7.2, and you've got to give him a diuretic, which you have to choose. Okay, all right. You will use thiazide. All right. Another patient who comes to you and he has a problem which you detected in his electrolyte report and the acid-base disorder, and he was having normal electrolytes, but his pH of the plasma was about 7.49 or 7.5 at that time when you saw the report, 7.49 or 7.5. So it means it is a little more than what you normally take, isn't it? So, what was your choice then? Okay. Alright. Okay. What else can you use? Carbonic anhydrase inhibitor, isn't it? Your other choice could be carbonic anhydrase inhibitor. Okay? But if you have an excess of carbonic anhydrase inhibitor use, then what will happen in the body?
Hypercaloremic metabolic alkalosis.
Okay, think and answer. In terms of acid-base balance, carbonic anhydrase inhibitor. You are inhibiting the carbonic anhydrase. Alright?
No carbonic acid before.
So what will you have as a side effect in the acid-base balance? This is the last question. What are you doing? If your carbonic anhydrase is doing what mainly?
Combine carbon dioxide with water.
Why is it combining to get what? What is your main idea about, what is your main purpose behind that?
Get hydrogen.
Loudly again, Renal.
Reabsorption of bicarbonate.
So, bicarbonates are not reabsorbed directly from the proximal tissues. Do you remember that? You need something indirect really, isn't it? They are filtered, but then, oh, how can I take it inside? Well, you've got to have something maujood at the brush border, luminal brush border. This enzyme is such a wonderful enzyme that it is maujood. If this is the lumen of the tubule, this enzyme is maujood here. Okay, so as this enzyme is there, bicarbonates are coming here, right? In the filtrate, the bicarbonates are coming. Hydrogen ions are also secreted from the tubules, isn't it? These two come together and they touch this enzyme here. Bicarbonates and hydrogen ions. This enzyme will catalyze the reaction. What will happen?
Carbonic acid.
H2CO3. Alright. Then what will happen? Break into what? Water is molecule here. Gas, carbon dioxide is there. Shh. it will go inside. Now carbon dioxide is inside. Now what will happen? Carbonic anhydrase again modules in kathir amount inside also. On the surface and inside. Now what will it do again? Again, you will form the bicarbonate ions. Hydrogen ions will be secreted again. Bicarbonate will go from the back door and they will go into the interstitial. Yeah. What did you do? You reabsorb the bicarbonate by a very special indirect mechanism, isn't it? You know that. If you are blocking carbonic anhydrase, first of all, what you are doing in the lumen, the first thing which you are doing,
Losing bicarbonate.
you are losing the bicarbonate. You are not reabsorbing the bicarbonate. Kathir amount of bicarbonate will be will be not reabsorbed and will be excreted. So what are you losing mainly? Bicarbonates. If you are losing your plasma bicarbonates, where is your balance shifted? So will it be metabolic acidosis or alkalosis this time? Oh, okay. It's good to clear. It's no problem that we are thinking in this way, but then we correct ourselves how it happens. Okay? You got that? So these are the examples how diuretics are affecting, which diuretics is doing what in terms of electrolyte balance and in terms of the acid-base balance. I hope now the concept is clear to you. Thank you very much.